Okay, well, good evening, everyone. Welcome from Boston, Massachusetts. My name is Regina Garland, and I work in the development office. And I am so pleased this evening, this afternoon, or this morning, depending on where you are, to welcome you to our presentation by Dr. Priya Garg, the Associate Dean for Medical Education. Right off the bat, I want to thank many of you for submitting questions. If questions come up during the event, please feel free to add them to the chat. At this point, I would like to turn the microphone over to Dr. Karen Antman, our Dean, for a brief welcome and introduction. Dean Antman.
Good evening. Terrific to have all the parents online. We look forward to a great dialogue, and hopefully we'll be able to answer any of your questions. And if not, we'll get back to you with the answers at some later time. Dr. Garg and her team have done incredible work over the last decade with several different variations to the curriculum to make the material easier to absorb. There's an enormous amount of material that needs to be absorbed in 4 years. And a sequence of revisions has occurred so that we now have a very integrated team-based curriculum for our first and second year students. I'd like to introduce Dr. Garg, who's our Associate Dean for Medical Education. Dr. Garg.
Hello, everyone. Thank you so much, Dean Antman, for that warm welcome. And it's so wonderful to see all of you today. Speaking with the students and their families is one of my favorite things to do and share what we've been working on in the curriculum. I just want to make sure, can you hear me okay, Regina and Maren? Great. So I thought I would start off, and what I'd love to do is if we could just put up the poll. I'd love to know who I'm speaking with today and who's in the audience. So Maren, if you could just put up the poll for a moment.
Sex discrimination is a term that...
So I'm going to end the poll. It looks like we mostly have students, mostly have parents that are from 3rd and 4th year, some from the 1st and 2nd, and some alumni. So it's wonderful to have all of you with us. All right, with that perspective, we can stop sharing the poll and we can close that up and we'll move forward. Are you able to move that from the screen, Maren? Oh,
yeah, on my end, it says it's ended. Sorry.
Perfect. We're all set. Okay, so what I hope we get a chance to speak about today is I'm hoping to give all of you an overview of the medical school curriculum, share a little bit about the redesign, which I think many of you are aware of, that we redesigned our curriculum in 2022, and share with you a little bit behind the why and how that all came about. We'll talk a little bit about the themes that have emerged and the outcomes we've seen since we launched the curriculum redesign, and then talk a little bit about the future of the curriculum. And I know that some questions were sent in advance. I'm happy to answer those at the end of the talk. And if there are more questions that come up throughout the talk, please put them in the question and answers. I'll answer them at the end. Since I mostly work in medical education, I do less of the residency counseling process, but I'm happy to try and answer those questions also at the end, as I spent the first decade of my career as a residency director. So we've just gone through this. So I like to start here because I know that not everybody is from a family that may have been in medical education or have gone to medical school. And many times students ask me to give them the big picture of what's going to happen. So as all of you are aware, your child is in medical school right now, which we call undergraduate medical education, the first phase of medical education. After that, you move into graduate medical education, which is residency as it's defined, or fellowship, which follows that. Generally, residency is somewhere between 3 and 5 years, and fellowship can be another 1 to 3 years. When you finish residency, you're considered independent and you can practice on your own with your license, and you don't need to be supervised. But up until that point, you must be supervised all the way through. And then after that, as many of you are probably aware, medicine is really a field of continuing medical education. We're always learning more and trying to improve our practice. And so it's really a program of lifelong learning. And one of the things I always want the students to remember is that unlike other phases of your education, the focus is really on trying to learn as much as you can to improve the life of patients, society, and populations, and not so much about yourself. So this is where we are, this is where we're going, and it's what we call it is lifelong learning. And that's really what your students are learning when they're with us, is how do you learn throughout your life? So this is a schematic of our curriculum as it is now. What you'll see is that there are 3 major courses in what we call the pre-clerkship phase of the curriculum, or the first 2 years. There is our basic science course, which is called Pisces, Principles Integrating Science, Clinical Medicine, and Equity. And it is broken up into a series of modules. Each of these little blocks are somewhere between 2 and 5 weeks long, and they're broken up by systems or body systems. The second course students take throughout the first 2 years is doctoring, and I'll go into a little detail of what that course is about. And the third course is a course called Leads, which is a health equity course, and that runs over 9 weeks. When you get to the final phase of our curriculum, which is 10 weeks long, we actually take the students through what we call advanced integration, where we're integrating all of the information that they've learned and taking them through what we call simulated clerkship weeks, where they spend a week where they're on the medicine service in the classroom and the pediatric service and the surgical service, so they can really understand what it feels like. What knowledge do you need? What skills do you use when you're in these discipline-specific weeks during the clerkships? And then they enter into their step 1 study period, just 6 weeks long, and then they go on to the next phase. In the next phase, they're in the clerkship phase, which begins with a transitional period for 2 weeks, where we prepare them with more information that's used in the 3rd year, and then they go through all of the different disciplines that vary in length from 4, 6, and 8 weeks. They have 1 elective during this period, which can be research, emergency medicine, or radiology. And then they enter the final phase of the curriculum, which is the post-clerkship phase, which is when you're studying for step 2, take a small course on some of the skills you need to transition to 4th year. You're required to do a geriatrics rotation, where we actually go into homes of our patients in Boston. They do a sub-internship in the discipline they plan to enter in residency, and then they have 24 weeks of electives, which are really their choice, depending on what they're interested in going into. So just to give you a little background, what we know in an article that was published in 2020 is that over the last decade, about 84% of medical schools have actually redesigned their curriculum, some for the second time, and are in some part of that process. We also know that in most medical schools, about 51% of the instruction is in lecture format, less than 15% is in case-based learning, and that 77% of schools in their first 2 years now have a pass-fail grading system. And that's true for our school as well, which has changed since 2014. It was 60%, and it's becoming the norm across the country. And then, as many of you may know, step 1, which is the first licensing exam that students take at the end of their first 2 years, became pass-fail in January of 2022. It used to be a 3-digit numerical score that was used for residency, and that changed. So in 2017, this is what our curriculum looked like. As you can see, it wasn't well integrated. It was essentially 4 individual courses running across the 2 years. We had outstanding faculty. Our students did quite well, but much of what's come out of medical education has been to really integrate between all of the different content, because that's the way we practice. And the second thing was that, like many schools, we had fairly low attendance in person because it was an all lecture format, and students today really can watch lectures at their own speed at home, and that was something true in our school as well. So that was something on our mind, and that is actually the year that I arrived at BU. And we decided to undertake a needs assessment, and we asked our students, our faculty, our leadership, chairs, our Dean's Advisory Board a series of questions. And what we identified were that there were some problems that were consistent across all of the groups that they recognized. And one of the things that was really said over and over is that we're not sure if our students are really ready for the ambiguity of medicine or the grayness of medicine. You know, medicine looks one way in a textbook. In the classroom, it looks quite different when you practice it. There's a lot of focus right now on the tests and really learning for the tests, where there's a lot of memorization that may be happening for the test, but then the information is leaving the students after that and maybe not being retained for the long term in the way we'd want. And there's some disengagement in classroom attendance. And then really what I was speaking about, this lack of integration between clinical and basic scientists. So really the teaching was basic science followed by clinical rather than seeing how they connect. And that students felt like they didn't have enough time for things like advocacy and social justice and scholarship in the way that they wanted. And we weren't really training our students to work in teams in the way that we practice. So we decided to think about what would we want to see change as we moved forward. And what we found is that we, as a community, wanted to build a curriculum and a framework that made our students participate in their own education. We wanted them to be part of their education and learning from each other in the same way that we do when we're in the hospital or in the clinical environment. We wanted their learning to be much more active and much less passive. We didn't want them sitting back and listening, but really engaging with us when they were with us in the classroom. And we want the students to recognize that the focus was on two things: step one, achievement, and we wanted them to be focused on their own personal development and learning how to work as a team in the class to achieve their goals. So we just developed new objectives for our medical education program, which you'll see here, and what's highlighted in red are really the things that we think about and hope for our students as we are designing our curriculum. This is what we want to see that they are able to do, and this is what we measure and assess throughout the curriculum. Do our students have the medical knowledge? Do they have the clinical skills and the reasoning that's needed as a doctor? Can they communicate with their patients and families? Do they know how to build an alliance with their patients and think about their patients' needs and develop that relationship and in a patient-centered way? Can they develop their own personal and professional goals? Are they able to think about health systems, and are they able to promote and advocate for all patients? And what I always say to the students and what we think about in the curriculum is that you always have to begin with the end in mind. So anything we design, we all have to think about as a community, where are we trying to go and what do we hope to see at the end of 4 years? So one of the things I like to make clear is that this wasn't something that we just woke up, 5 years later in 2022 and did. We actually have been changing the curriculum over time continuously and really piloting and trying things with all of the classes that came before. So what you'll see in the schematic is that we started, like I said, with focus groups, but we also started a multi-year plan where we began to cut content, have our faculty work together, begin to think about what does integration look like. We redesigned doctoring first, then we moved to the basic sciences, then we developed LEADS, the health equity course. We started our new formats of teaching in 2020, 2021, and then began with all of those formats coming in to the curriculum after having been piloted for several years. So this is what it looks like when you're in the classroom with us, and this is what it feels like. So this is our fourth floor of our L building. You'll see the students, they're all working in teams together. They're in groups of 8 in the curriculum. Those teams switch at different points in time. And you'll see that the faculty are at the same level as the students. They walk around when we're in the classroom. We want to really be engaging with them directly and them engaging with each other. And to redesign the curriculum, I always like to share that you really have to build an infrastructure. And I want to thank Dean Antman and the school, because this could not have been done without the support of the deans and chairs. Everyone in leadership has to understand the change and really supported it by supporting the faculty and providing with the development they needed. We needed new technology and new systems in order to support this new design, and we needed a new space, which I showed you. And with that, we will have a new clinical skills center and simulation center that's also about to begin its construction, which will come as the next space that we're redesigning for the way that students need to learn. So one of the questions that came through before the webinar is, how would we describe what makes students different or unique at our school? And what are we really hoping for our graduates? And I share this slide with students when they come, when they've been accepted to the school. I show it multiple times to our students. And I say the first and foremost thing is we want you to be exceptional clinicians. That's always the most important. We need you to have exceptional clinical skills, and we want our students to be known for that. And we know when we hear from residency directors, that is something that stands out in our students. But we also want them to have leadership skills. We want them to be able to drive change in health and providing equitable health for all people. We want them to have scholarly careers. So whatever that academic career is, it could be research, be medical education, like my career. It could be in public health. We want them to find that scholarly passion of theirs. We want them to work in teams and learn how to do that and how to collaborate with others. We have many students who help us design and think about their education. They are in a different generation than many of the faculty, and so we're always listening to their input. And then finally, we want them to love this profession. We don't want them to burn out early on. We want them to figure out what makes them love what they do and how we support them through that. So just to share some of those goals, so in terms of exceptional clinical care, our students in our school start seeing patients within the first 2 weeks of medical school. We send them into the hospital with fourth years who teach them, and many of our students go on to do that elective in their fourth year and love teaching their first year peers. We have 40 faculty who apply for a position. There are 40 of our best educators. They're in what's called the Academy of Medical Educators. They teach the students in the doctoring curriculum over the first 2 years. What's unique about this is that they serve both as their advisor for 4 years and teach them in the first 2 years. So they develop this wonderful relationship with the students for the entire time, which helps really the students to learn and feel comfortable, also allows them to ask questions about careers and the path that their faculty took. They go into the hospital in the third year and they actually give feedback to the students that they've known for 3 years. They're not grading them, but when you enter a new hospital environment, it's very stressful for students. And so they have that relationship with someone they've known for a very long time. And we use actors and sterilized patients in simulation. And for a long time, we used to call these soft skills, but I'll be honest, these are the hardest skills. These are the skills of being a doctor every day, thinking about how you're going to reason through and manage patients and how you're going to present with the team and document and examine the patients. So we think this is a really important program in the school. And here are some pictures. We have a whole ceremony where we give our students their stethoscopes. It's supported by Alumni Association. You'll see the students in the corner, how exciting it is. We always have a keynote speaker who shares their journey through medicine. And then this you see over here is an example of a student working in our clinical skills center and learning some of the skills of physical examination and blood pressure. I also like to share the data because I want to make sure that everyone's also aware that we vision one thing, but we want to make sure it's actually coming true. And so what we know about our Academy of Medical Educators is that we do ask the students to evaluate them every year. And for the last 3 years, the entire cohort of faculty have been rated greater than 95% of the faculty are rated as the students strongly agreeing that they show enthusiasm for teaching, that they're effective at teaching, that they give them feedback. And it's very rare to have this large of a cohort of teachers who perform that well. And so we really are proud of the faculty for the dedication they have for the students. And here's a quote that's from one of the Academy of Medical Educators. And just to give you context, the AMEs, as we call them, are clerkship directors. They're faculty who teach across many, many different specialties. They're in practice and also doing this in teaching. And what you'll see is that one quote is here: I absolutely love getting to know more students really well. The longitudinal relationship is just awesome. My first cohort of students graduated this year and I felt so totally proud of them. It's really wonderful to see them develop over time. I also think that teaching clinical skills is great because most students come in knowing very little bit about that. Plus you're really teaching things they'll use their whole career. So it's an impact that is on both sides, both for the students, but also for the faculty. And what we also have seen is that we give our students an exam with sterilized patients where we run them through cases to see what skills they're developing. And we used to give this exam at the end of second year to all the students. And you'll see that these are their scores in being able to take a history and communicate with their patients and do a physical exam. We now give the exact same exam with patients at the end of the first year. And you'll see that all of the students in the first year outperformed the students at the end of their second year in these skills, which tells us that us introducing clinical skills early and in a very robust way in the first year is actually being seen in the way that students perform. And that's what we want for our students to really advance in their skills quickly so that we can continue to provide them with more and more teaching around clinical skills. The other thing I'd like to share is that our curriculum is based on educational theory and evidence. So in the same way we want our students to learn the science and evidence of the diseases that we think about and the way that we diagnose and manage patients, we also have built the entire curriculum on the evidence and science of learning. And we use cognitive psychology to really build the way we teach. And that is one of the reasons that we instruct our students and use the curriculum design that we do. And this is a wonderful book, if you haven't read it, that talks about the science of learning. So in the students' very first week with us during what used to be orientation, we actually share with them and are very explicit about this is how people learn. This is what we know works for learning. This is how you hold on to things in your memory so that all of our students are set up for success and learning. We're not trying to hide anything. I tell them we're not trying to weed anyone out of medical school. We chose you because we want you to be doctors from BU's Chobanian Avedisian School of Medicine. And these are the things that you need to think about when you begin. How do people learn? What is the way we learn in medicine, which is complex learning? How do teams work? And we start training them in that first week. We also use a variety of learning formats. So our students are in a flipped classroom for part of their curriculum where we provide them with video and text in advance that are created by all of our faculty. We then have them do a short quiz to see what they've learned, and then we bring them into the classroom and we do what's called application sessions where we actually use real patient cases to apply the information. So when students who have been in our school before and have been part of a master's join the medical school, it is a very different curriculum. You might have learned physiology before, but now you're learning physiology applied to the way it's seen in patients. And so we really want to make sure the students understand that difference. And then we use an instructional method called team-based learning, which I'll share in 1 minute. We also always have open discussion sessions, times when the faculty are in the room and students can just ask questions and clarify any gaps they have. And our faculty run office hours, and we have group tutoring run by students and individual tutoring as well. So you'll see students here in their team-based learning. I have a link to a video, which I'm not going to play now, but if anyone wanted to watch that and learn more, I'm happy to share that. But why do we use team-based learning? So team-based learning has been shown that when students work in this format, it actually helps them to perform better on their exams. And what team-based learning is students come in, they have prepared themselves at home and read some materials. They come in and they take a test in the classroom by themselves. It's a short quiz. It's usually only 5 to 7 questions. Then they're not given the answers to that quiz, but then are asked as a team to take the same quiz and see how they do and see what answers they come up with. The answers are revealed to them and they're able to see how the team did and how they did individually. The faculty clarify any gaps, and then we give them even harder questions where they have to apply the knowledge they've learned in those tests in cases. And so that's really the process we take them through once a week. And the reason we do that is because one of our goals is that we want them to learn how to collaborate and share ideas with their team. I tell the students when you're on the floors, when we're seeing patients, you're going to have to speak with the nurse, the pharmacist, the nutritionist, and share why you're taking care of the patient in the way you are. And so that's a skill we want them to learn to develop in the first 2 years. And what we found from our own data is that what you're looking at in these brown bars over here on the left is this was the mean score of the students when they took the quiz by themselves. So these are each of our courses that run. And you'll see that when in the class, the mean score for the quiz for that TBL was 83% when the students took it by themselves. But when they worked on the same questions without the answers as a team, the mean score was 98%. So we know that without giving the students any additional knowledge or information from the faculty, working together raises their score across the board. And TBL data from the past has shown that even the lowest performers, even the highest performers will perform better when they work in teams. These are just some quotes as well from students. This is from our class that's in there, just joined their 3rd year, the very first class to go through the redesign. And you'll see that the students love working in teams. They see both the benefit for their own personal and professional development, but also for their learning. With this class, when we told them that we were going to change the teams after 6 months, they actually asked us not to change the teams because they enjoyed working so much with their peers and want to stay with the same group. And so this class actually went through a year plus of the curriculum before we changed their teams with a different group of students. And the last piece that's very important to me is that this student evaluation data shows us, we ask the students, tell us if the Pisces team has impacted your well-being and mental health. And you'll see that over 3/4 of the class said that being in these teams not only impacts their learning, but also their well-being and mental health, which is something emerged that we didn't know would happen from changing from the prior curriculum to the team-based curriculum. So the other piece, as I shared, is we want our students to really be leaders, and we want them to drive change. So we established some new health equity objectives in the curriculum that were new. And really what we want for our students is for them to be able to identify ways that they can advocate for a more equitable healthcare system, one that we know can function better than it does. We know that we are one of the wealthiest nations, but our healthcare system could use many improvements in terms of how we think about caring for all populations. And so that's really what we're trying to teach our students and have them be scholars and thinking about how to move that forward. So through our class leads, we have the students learn about health systems, about population health, about structural drivers of health. We have them work in the community, do service learning, and we have them work in groups to formulate a project after they are taught by experts. And at the end of their first year, they actually write a narrative, an opinion piece that could be published in a newspaper. Last year's class actually two groups submitted their op-ed to the Boston Globe because of what they wrote about and what they thought about. And then we want them to propose a project. And here is the end of second year. These were our students in the class of 2026, all presenting posters, project ideas. These are all the different tracks in which they can work in and think about. And they're sharing, and faculty came by and actually we gave awards for projects and really wanted the students to engage with our faculty with their ideas. And here is the program that you'll see. You'll see students were also presenting their ideas we were teaching them how to give oral presentations, as well as how to create posters and how you share and disseminate your ideas with others. And these are all examples of different projects that the groups worked on. And the last piece is that we've spent a lot of time also thinking about the exams that we give the students, and really have spent time where we have worked with the faculty to make sure that our questions are similar to the way that Step 1 and NBME thinks about questions, which are really at the application level. We don't want to be asking facts that people just have to memorize that you could look up. We want our students to have higher order questions that force them to apply the information. And so that is also a change that we made as we moved with the curriculum. So just to summarize and end, what I think has brought us to where we are in the curriculum today is that our faculty have created all of the material, but have had to work across disciplines, across different courses, different phases. And because the whole group is working together to that final outcome I shared with you, it's changed the way the faculty think about what they're teaching. We made small changes over large periods of time, but we have a shared mental model on what we're trying to achieve. Our faculty and the administration are very student-centered. We really want the best for our students. We know that they are so bright and they have been so flexible through the changes. And we also are always trying to improve and open to feedback. So with that, there were a few questions that came through before the webinar that I'm gonna try and answer. But if you have other questions, please put them in the chat, or you're welcome to ask them. I'll close this screen after I've answered these few questions. So let me just start with, there was a question about nutrition in the curriculum. So nutrition is taught, it's taught in GI, and it's also taught in endocrinology. It was a theme that we looked at as we redesigned the curriculum. One of our faculty actually is a national leader in nutrition education, Corinne Lunders, and she helped us to design and think about what we should teach. And we also think about, within the nutrition realm, we think about food insecurity as well, and teach our students about food insecurity as part of our curriculum. In terms of step one changes and national pass rates. So some of you may be aware that when step one went pass fail, there was a national drop in the pass rate across the country. The current national pass rate for step one is 92%. Our school also saw drops, but we still remain 2 to 3 percentage points above the national pass rate. So last year, our national pass rate was at 94%, and when the national average was 92. We haven't had all of our students finish taking step one yet, so we don't have the data yet. It usually comes out several months delayed, so we don't know what it is for the class that's in the class of 2026 yet. We have a very deliberate step one board review process. So our students actually are required to do UWorld questions within our curriculum, which are questions that most students use in preparation for step one. We also work with them quite closely in developing a study plan through the dedicated period. And we basically, the way we think about our students in terms of passing is we have them take self-assessment exams at multiple time points that come out of the National Board of Medical Examiners, which give a prediction to your pass. And we recommend to students whether they should take step one or not based on their performance on those self-assessments. I think I shared what we offer that other schools do not. I think we have a very unique curriculum, a very unique patient population, and very unique students. And I think all three of those things create leaders and scholars, and we have seen our students really successful both in publishing many papers across the last several years, but also in developing curricula and being national leaders in different organizations. And so I think that is really something unique to our school. And in terms of the residency process, I'm just going to stop sharing my screen. So I can only give you the big picture as someone who used to be a residency director in pediatrics. For 9 years, I was the residency director at Tufts in pediatrics before I came to BU. And the process, I'm happy to go over. So students in their first year really start exploring different disciplines that they're interested in. We have many shadowing experiences. We have over 100 student organizations. We have faculty who bring students in who are working with them on different projects, and the students get to see what the different disciplines are like. They begin doing research, they begin doing community projects, and usually they start to think about what they might want to go into sometime in their second year, but it's the clerkship year and the third year where students really get to see everything. And what I tell the students is the reason many people make the decision there is because you not only see the discipline, you see the culture of the discipline, you get to see what is the lifestyle like, you get to see what kinds of patients you'll see there, you get to meet the faculty in depth. And so students by the end of their third year make that decision. And then in their fourth year, usually in January of their third year, they put in for their schedule of what they're interested in. And then in fourth year, they explore that and they have to put in their residency application by September through the ERAS system. And so students really need to have their letters of recommendation and their application complete by September of their fourth year. The match happens in March of their fourth year, which is when they're told through a computer system that where they will be going for their residency. So I will stop there and I'm happy to take any questions.
Thank you, Dr. Garg. Please, everyone in the audience, if there are questions about medical education or questions specific to the Chobanian Avedisian School of Medicine, feel free to enter that into the meeting chat and we will field the questions. Well, Dr. Garg, I think you have done a fantastic job outlining the medical education process and the overhaul that you and your team have so successfully done at the School of Medicine. I'm not seeing any questions in the chat. I will say, for those of you that had very specific questions about residency, please stay tuned. We hope to offer additional programming coming this summer with faculty. Oh, here we've got a question, but with faculty regarding residency. Dr. Garg, this one is getting at residency. Perhaps you know the answer, or Dr. Antman can chime in. What percentage of your students get residency at BUMC?
I don't know the number offhand. Dean Ammon, do you have an idea?
It varies widely from about, the classes are usually about 150 students, the graduating classes. And over the last 4 or 5 years, it's varied from about 18 to 24 students stay at BMC. So that would be about 15 to 20% stay at BMC.
And I think as a follow-up to that, many of our students also want to leave Boston for residency because they're from many different places, because we have a very geographically diverse student body. And so that is, not all of them necessarily want to stay here, which plays out in the match. Yeah.
Are you seeing the next question, or do you
I
want?
am.
Okay.
So I'm happy to answer. So there are 3 step exams that happen. There is step 1 that happens at the end of your pre-clerkship phase. So typically your first 2 years. That one's really focused much more on basic science. It is probably what most of us would say is the most difficult of the 3. Although it's pass-fail, it's still quite difficult because there are many facts that students need to know for that exam. The next one is step 2, which happens at the end of, at the beginning of 4th year, after you've completed your entire 3rd year. Throughout 3rd year, there are exams that our national exam students take, which are called shelf exams, which really prepare students for step 2. So our students also typically, that is still a 3-digit score. Our students typically score about 10 points above the mean on step 2. And they're really well prepared because much of step 2 is clinical. And so students are really seeing that. So they generally only need 3 weeks to 4 weeks to study for that. And then the last is step 3, which is typically taken after the first year of your internship, which is also very clinically based, and most people do well, and we haven't seen any data that suggests our students are not doing well in step 3, and then you have to take your board exam in your specialty after you finish residency. So progress indications, I'll just say for step 1, what we're really following, and what I share this with students, if any of you have a first year, they might tell you that I had a talk with them last month and shared with them that the indicators that are linked to how students do in step 1 is first your performance in the curriculum. So in general, if students are passing our exams, are scoring at least at the mean or above the mean, they likely will have the foundation needed to go into the dedicated study period and do well. The second indicator is the self-assessment exams that we have them take that come from the national board. Your score on that provides a prediction of how likely you are to pass step 1. So that's the other process indicator we use. And the third is that as students do UWorld and they get closer, we have them look at what percentage they're getting correct. Generally, if you're getting over 60% correct, you're likely to do well. So the next question is from Chris Song. When students get assigned for rotations in 3rd year, and if they're not given the opportunity by the resident to participate and learn, what is the channel they can go through to improve the situation? That's an excellent question. So really, I'll broaden that to how do we monitor the learning environment in the 3rd year. So our students, there are a few ways. So the first is the students can always reach out directly to the clerkship directors and talk about their experience. We're always monitoring to see what their experience is, both with their residents and the faculty. They don't feel comfortable with their clerkship director. I and Dean Jackson, the Dean of Student Affairs, are always available. We also run what's called learning environment sessions. So in every clerkship, towards the end, students in the years above facilitate small groups where students can share anything that is happening in the environment they're concerned about. And that comes back to my office and we ask the clerkship directors to respond. We also have an anonymous reporting system for any mistreatment that's evaluated by a separate committee monthly. And then we do course evaluations that the students are required to do at the end of the clerkship, and we monitor that closely to see what the comments and performance. And actually, every faculty and resident is evaluated by the students. That data goes back to the department regularly, professionalism data every quarter, and every 6 months, the performance of the teachers. And we ask the chairs and residency directors to respond if we have any faculty or residents of concern. I will tell you that we monitor resident teaching and faculty teaching, and across the clerkships, the students strongly agree that the resident teaching, greater than 90% of the residents, they strongly agree are effective and outstanding teachers. So we have really wonderful resident teachers and faculty.
Again, Dr. Garg, thank you. And another question regarding new curriculum being established. Do you feel that there was enough time in the schedule for the students to study for the Step 1 exam this year?
Yeah, that's a wonderful question. So we gave the exact amount of dedicated study that we always had with the curriculum redesign. And so they had 6 weeks. We embedded UWorld, which we've never before the curriculum redesign required students to do board review questions. And what I will say, the honest reality is that with Step 1 moving past fail, and just with the general system and pressure that students are feeling, we nationally across the country are seeing that students are really feeling like they need more time in general, because what we think is that students are doing so many extracurricular activities in their first 2 years, trying to distinguish themselves through research or leadership, that they're doing the curriculum, they're doing all these other activities, and then they're also studying for Step 1. And I think the students feel a lot of time pressure because they're navigating all of those pieces. So I think that we did give them enough time. I think what we needed to do better, which we've shown students, is really highlight in the curriculum when we were teaching them board content. I think what we didn't do is really make it explicit to them. This is a concept that is on the boards. We're teaching it to you. Be aware. And so we're trying to be much more explicit with the students so that they're doing that in parallel. But data shows that if you extend the dedicated study period for too long, students actually have lower performance because they're studying for too long a period, and they start to lose that knowledge because they start to get burnt out. So almost all schools across the country give somewhere between 5 and 8 weeks in the dedicated study.
And we have another question. Did you see?
Yep. How is the second year different from first year clinical experience and such? So in the second year, so for example, if you take physical examination in the first year, we're teaching you the systematic process of how to examine a patient from head to toe. In the second year, we have them more take into account their diagnostic reasoning. So really thinking about, given that you have this patient with this concern, what maneuvers would you use that would help you to think about and give you more information to figure out what the diagnosis is? How do you use the physical exam to advance your diagnostic skills? So it's a little bit moving from, I just understand how to do it, to I understand how to apply it. The same is true about the differential diagnosis and diagnostic reasoning process. In the first year, we're giving them the knowledge and the foundation. We're giving them the almost the formulas, the way we ask questions. How do we interview patients? How do we take that information? How do we document that information? All of the templates we use. In the second, we're asking them, you've been given the template, but now you really need to think about how you integrate that information to figure out what's going on with the patient. And we do that both in the classroom and in doctoring. So in the classroom, we also are giving them more and more complex cases. Like I said, in the last 10 weeks, we give them cases in the same way we see them in the hospital. We don't tell them you're now in the heart or in the cardiovascular system and all the cases have to do with the heart. We say you're now in the medicine service and you could meet any of these 6 patients. What could be going on with them and how are you going to figure that out? So that's really how we advance them.
Thank you. Last call for any questions for Dr. Garg. In the meantime, for those of you that are parents of fourth years, I'm sure we will see you Sunday. I would like to remind you, from time to time, you may hear from me and my colleague, Suzanne Maselli, and I encourage you to take us up on an opportunity to chat. We want to learn about your experience as parents. I'm seeing another question. Can you talk about research and how important is it in terms of residency application, and how much time should students spend on research or priority should be given?
Yeah, so this is a question that students ask all the time as well. And I think it really depends on the discipline you're going into. I think as a school, we feel that the skills you learn when you're doing research are quite important for anyone's academic career. That process of critical thinking is quite important, which is why we've embedded that scholarly piece into our LEADS curriculum and thinking about how would you formulate an abstract, or how would you present your a project or your thoughts. But in terms of, do you need to do basic science research, or do you need to do clinical research? I think it really depends on what the student is interested in terms of developing their career, and where they see their career going. And there are disciplines, I would say, like orthopedics, dermatology, otolaryngology. Those are disciplines where research is quite important, and the faculty will guide the students to let them know that those are fields that are looking for students to demonstrate they've done research, versus, for example, in pediatrics, my field, if students are demonstrating advocacy or leadership, or community service, that may weigh as heavily as research at some of the programs. If you want to go to some of the top programs, in certain programs, it's known that research is a very important thing that they're looking at as a factor. So I really think it depends on where the students want to go, what they want to do with their career, and what they see. I don't know, Dean Antman, if there's anything you want to add to that.
Oh, I think you covered it very well.
Yes, and graduation's Thursday, so we want everyone to show up Thursday, and we look forward to seeing everyone there. I will say what's fun looking at this list is that many of your last names are quite familiar to me, because I've met with your students. I met it with about 60 first years in the last 6 weeks, and your questions are very similar to theirs. So hopefully, but what I say to them, which I would share with everyone, I think just to end, is that, I think if your student is early in their first 2 years, what we really want them to do is to explore medicine in a way that they can understand all the different paths you can take in your career, which is something you don't usually know when you start. And so we really try to counsel the students that they should explore the things that they're interested in, and meet with as many faculty as they can to understand all the different career paths that are possible. There is one more question I see in the Q&A. Let me answer that for Michelle. Yeah, so I think this question of distinguishing yourself is, so what happened, the reason that that step one was changed was that when it was a 3-digit score, that was exactly what was happening, was that residencies were using it to distinguish, and decided that the higher the score you get, the smarter you must be and the better you must be for a field. But the exam, in terms of its psychometrics and the way it was created, was never created to distinguish people. It was created to create competence. And there's no data that showed that just because someone got a 240 versus a 260, that they would be better in a field, better as a doctor, or better overall. And so that's the reason that it went to pass fail, because there are many people who thought it was being used inappropriately. Of course, as you're pointing out, it then just put the pressure to other time points, because how are students going to distinguish themselves? So now what's happened is that step 2 will likely be the score that more people look at. And again, in terms of distinguishing themselves, yes, students are right now, what we know is that the third year grades are the most important thing in residency selection. So your performance in the third year. So that's why we tell the students to spend so much time really focusing on doctoring and the medical knowledge, because that is how you perform well in the third year. And then I think it's really developing your narrative as a student of what you've done, what interests you in medicine, and how you are going to demonstrate that you'll contribute to the field. And that can be done in many different ways, but that's really what is going to distinguish people.
Dr. Garg, this has been an amazing opportunity to learn a lot about the medical education at the Chobanian Avedisian School of Medicine. I know I learned a lot, and I'm sure many of the parents here agree. We appreciate all you have put in to the curriculum, along with your staff and colleagues. I'm not seeing any more questions in the chat. As I started to say earlier, my direct supervisor, Suzanne Maselli, the Associate Dean of Development, and I spend a lot of time on the road meeting with alumni and parents. And it's important for us to hear the stories and learn a little bit about what you're hearing about medical education and the experience of your students. When you hear from us by email or phone, take us up on the opportunity to talk. Again, it helps us, it creates a sense of community. So we are grateful you joined us this evening. Look for further communication from the School of Medicine this summer as we plan additional programming related to the experiences your students are having. Are there any more questions? Any last comments, Dr. Garg or Dean Antman?
No, I think I would just say to all the parents, you have amazing children. It's been such a pleasure to get to know them.
And I'd like to thank Dr. Garg for a terrific review of the curriculum.
Yes, thank you. Well, with that, we will end the live recording. This will be posted on our website. I will make sure that you have a link to refer to this in the future. Thank you very much and have a wonderful evening, afternoon, or morning.
Thank you.